In Chapter 9, we will go over bloodborne pathogens, universal precautions, and wound care. Bloodborne pathogens are, by definition, organisms that are present in human blood and other fluids that can potentially cause disease. So, bloodborne pathogens are not just carried in blood. They could also be carried in urine, saliva, stool, things like that. This is one of the main reasons why fitness and healthcare facilities must be clean and/or sterile to prevent disease or infection. We don't want to pass along these bloodborne pathogens to other members of a gym or other athletes or patients. Our most significant bloodborne pathogens are hepatitis B and C and HIV. There are other bloodborne pathogens as well, such as hepatitis A, D, E, and syphilis. And we'll talk about those on later slides. As far as hepatitis B, this is a virus, so we will distinguish between viruses and bacteria when we're talking about the different types of pathogens and infections that people can get. So hepatitis B is a virus. With hepatitis B, the signs and symptoms would be flu-like symptoms. So a person could feel fatigued or weak or nauseous, have abdominal pain, headache, fever, jaundice. So jaundice is a yellowing of the skin or eyes that occurs when somebody's liver is stressed, and hepatitis in particular attacks the liver. But the really scary thing about hepatitis B is that the person actually could be asymptomatic. So that could mean that they just don't feel sick at all, but they've become infected with hepatitis B. So because of that, it can be unknowingly transferred from one person who's sick to another person who is well, because the person who was sick didn't even realize they were sick. The nice thing about hepatitis is that about 85% will recover in 6 to 8 weeks, but other people will need more treatment. So as far as prevention, we want to prevent this, first of all, by getting vaccinated. So this is a set of 3 shots that most people will get when they are young children, and then also they usually do a booster in teenage years. I think sometimes it's a good idea to do it later. I can't remember exactly how long it lasts for, maybe 10 to 15 years. I can't recall. But I think it depends on the individual's metabolism as well. We also want to practice good personal hygiene here. So hand washing, avoiding touching other people's bodily fluids, things like that, and avoiding high-risk activities. So we want to avoid high-risk activities like unprotected sex or sharing needles or getting tattoos in places that may not be reputable, things like that. Hepatitis B or HBV can survive in bodily fluids or dried blood for about a week. That's really scary. So that means you could accidentally touch somebody's dried blood that is about a week old and still get hepatitis from it. So this is one reason why we do try to practice universal precautions always, even if the bodily fluid seems old, we still want to make sure that we're wearing gloves when we're cleaning things and whatnot. Another type of hepatitis is hepatitis C. This is also a virus. Hepatitis C is the most common chronic bloodborne infection in the US. It is rarely spread through sexual contact, so it's possible but not as likely. It is most often spread through contact with the blood of an infected person, so from sharing needles or items that carry blood, like a razor where somebody may have cut themselves, or even a toothbrush. You may not realize it, but sometimes when you're brushing your teeth, you cause a little damage to the gums and you can cause some bleeding. So sharing a toothbrush with somebody that you don't know very well is a really bad idea. Hepatitis C is the leading cause for liver transplant. As far as signs and symptoms, kind of scary, just like with hepatitis B. A lot of people who have hepatitis C don't have any symptoms, so they may or may not even know they're sick. Only about 80% of people with hepatitis C are asymptomatic. When people do have symptoms, they'll have jaundice, which is the yellowing of the skin or eyes. That's telling us that the liver is stressed. They'll have mild abdominal pain, loss of appetite, nausea, fatigue, muscle or joint pain, and or dark urine. Ways that we can prevent getting hepatitis C ourselves are, like we talked about on the last slide, always following blood barrier precautions, so wearing gloves when handling somebody else's bodily fluids, and also considering the risks of getting a tattoo or body piercing and making sure that you're only going to a store with a good reputation that seems very clean, where they open needles in new packages directly in front of you and they wear gloves, things like that. As far as management, there's no vaccine for preventing all types of hepatitis C or HCV. There are some treatments for certain kinds of hepatitis C, but there are not medications for all kinds. So the most commonly used medications for hepatitis C are interferon and ribavirin, and that seems to be the most effective, although there are some newer medications as well for certain types of hepatitis C. Drinking alcohol can make it worse. Drinking alcohol will stress the liver that is already stressed from the virus, so it's ideal for somebody with hepatitis C to stop drinking alcohol and be careful with the medications they're taking outside of their prescribed medications. The other thing that's a little scary about this is that it's not checked for in regular routine lab work, so it's something that somebody would have to specifically request to be checked for. Another scary virus that most of you have hopefully heard of previously is human immunodeficiency virus, or HIV. HIV is a virus that has the potential to destroy the immune system. It's transmitted by infected blood or other bodily fluids. Our signs and symptoms could be fatigue, weight loss, muscle and joint pain, painful or swollen glands, night sweats or fever. That's a fairly common sign of HIV. The kind of scary thing is that it can take up to a year after exposure for the blood test to detect HIV. There are some more modern tests. There are tests that can be done that give us a better idea sooner, but if somebody is exposed to HIV, they'll want to continue follow-up testing for up to a year to make sure that they really did not get infected. It may be 8 to 10 years before signs and symptoms develop. So with individuals who have been exposed, they may or may not know they're infected. So that's the scary thing about a lot of these viruses, is that people don't always know they're sick. And you can be exposed to the virus without even realizing that the person that you've been with or that you had contact with was sick. Most people that acquire HIV will develop AIDS. There are lots of different reasons for that. We do have a lot of really great medications for HIV now, but they're expensive and some of them aren't covered by insurance. So that becomes really difficult and costly for people dealing with this disease. So AIDS stands for Acquired Immunodeficiency Syndrome. This is what happens once HIV has advanced further. And it's a collection of signs and symptoms that is recognized as effects of an infection. And it's systemic, so it's not like one body part that it necessarily attacks. But basically somebody with AIDS has no protection against the simplest infection. So somebody with AIDS could die of a cold or a splinter that got infected or something like that. Positive tests for HIV cannot predict when the individual will show symptoms of AIDS. There are some people who were born with AIDS or with HIV because their mom had it and never develop signs of AIDS up until even being in their 20s. And some people will develop it very quickly. After contracting AIDS, people generally die within 3 years of the symptoms developing. So it's relatively quick. As far as management goes, there's no vaccine for HIV. A lot of people have been working on that for a long time. There's no cure. There are drug therapies available, and the drug therapies have gotten more specific for each strain of the virus and better. So again, the drug therapies can be really good, but it's more of a matter of whether or not somebody has access to that, because it can be cost prohibitive. Research for preventative vaccine and effective treatment is always ongoing for this. Generally speaking, when people do have HIV and they're trying to avoid getting AIDS, they'll be getting an antiviral drug cocktail. So people with HIV take a lot of medications to try to slow the reproduction of the virus and improve their survival rate. And some people with HIV have great survival rates. I mean, Magic Johnson has done amazing. Like, he's been not even shown signs of being sick really, because he can afford the best drug therapy. He doesn't have to worry about that, whereas other people might have a more difficult time. As far as prevention of AIDS, the greatest risk of AIDS is through intimate sexual contact with an infected partner. So practicing. As far as HIV and athletic participation, the chance of transmitting HIV among most athletes is very low. So there have not been any confirmed cases of HIV spread through sports, but there's definitely a higher chance in theory for different types of sports like martial arts and boxing and wrestling. So I believe I had a previous student who was a boxer who told me that at certain levels of boxing, they actually do require them to have blood work done showing that they are HIV negative. That's not as common in martial arts or wrestling, to my knowledge. So again, with Magic Johnson, that's part of why he was allowed to continue playing professional basketball after he was diagnosed with HIV, because the chance was so low of him spreading the disease to anybody else. If somebody has known HIV, we should try to limit bodily fluid contact or avoid that. But HIV isn't really spread through sweat; it's spread through blood. So as far as sweat, that's not really as much of a concern. Probably the bigger concern for the participant that has HIV would be avoiding exhaustive exercise, because that can lead to susceptibility to infection. As far as participation being allowed, we have to be careful with that, with trying to disqualify somebody because of HIV, because the Americans with Disabilities Act says that athletes infected cannot be discriminated against and may only be excluded with medically sound basis. So if somebody is disqualified, it has to be based on objective medical evidence, and it has to take into consideration the risk to the patient and other participation, and be a means to reduce risk. So again, most likely this would only happen if there was a higher risk, like in martial arts, boxing, wrestling, maybe rugby, where there's a lot more blood contact in the sport. So we've already talked about universal precautions a bit on previous slides when we were talking about the different types of viruses that were relatively dangerous. But universal precautions in athletics and in fitness centers and places like that is very important. Universal precautions were set up by OSHA, or the Occupational Safety and Health Administration. And basically what the universal precautions are standards for employers to follow that govern occupational exposure to bloodborne pathogens. So individuals should be given training on how to deal with bloodborne pathogens if they are expected to manage them. So say for instance, when I was working in athletic training programs, we were required to have a short OSHA bloodborne pathogens training yearly to make sure that we understood how to manage bloodborne pathogens and use universal precautions. These guidelines or standards were developed to protect healthcare providers and patients. So for athletics, prior to participation, all open wounds and lesions should be covered with a dressing that will not allow for transmission. So if we put a Band-Aid on somebody and it doesn't fall off while they're working out in the gym, great. If I put a Band-Aid on a sweaty rugby player for somewhere they're bleeding and I don't cover it with tape, it's going to fall right off. So I need to make sure that I'm covering it appropriately for what the patient or the athlete is going to be experiencing. I actually unfortunately had to pull one of my rugby, or I didn't, the referee did, but one of my rugby players was removed from play because I couldn't cover a laceration that he had going through both of his lips this last season. It was right in the middle of his face and I didn't have any way to cover it to make it stay covered while he was playing. And unfortunately he missed the last few minutes of the game and we ended up losing the game. Rugby is not about individual players, so I don't feel as bad, but he definitely would have been helpful for the team to have him in the game. So if I can't cover it, if I can't keep other people safe from being in contact with his blood, then he can't keep playing, unfortunately. In the pool, sticking a Band-Aid on something, unless it's a waterproof Band-Aid, is probably not very effective as far as transmission. So that's another thing to consider as well. We need to cover something with a waterproof dressing for swimming or water polo. As far as bleeding during games and activities, like we talked about, athletes with bleeding are going to be removed from a game and they can be returned when it's stopped and covered so that it won't be transmitted or touch another athlete or participant. If somebody has got blood enough to bloody their uniform, it needs to be removed if it's saturated or cleaned with a small amount of hydrogen peroxide to remove blood if it's a small amount of blood. As far as saturated goes, I haven't had too many athletes actually saturate their jerseys. I did have one female rugby player once who had a laceration over her eyebrow and she was bleeding like crazy. It looked like she had a blood bib on her white jersey and it was bloody to the point where I could basically wring the blood out of it. When we took her jersey out, I was able to wring the blood out of it. So in that case, we're not going to be able to clean that up with hydrogen peroxide. She needed to change her shirt. So if it's saturated, the uniform is removed and is treated with universal precautions to try to make sure that we're not having anybody touch the blood. And then if it's just a small amount, we can clean it up with some hydrogen peroxide. So personal precautions are how we follow the idea of universal precautions. So we will be using equipment and techniques to make sure that we are not exposing ourselves or other people to somebody else's blood or bodily fluids. So we're going to want to use appropriate equipment. So we want to have first aid kits or emergency kits available that contain blood, resuscitation masks. People often vomit during CPR, so it's important to have a mask covering their mouth if we're going to be performing rescue breaths, and towelettes or other solutions for cleaning skin surfaces. We always want to put gloves on before any chance of contact with blood. So for me, if I'm on the sidelines working rugby, I don't keep gloves on all the time. Some rugby athletic trainers do. But for me, I'm watching the field close enough so that I can see when somebody's starting to come off the field with blood. The first thing I do is pull out my gloves and start to put them on. If the individual gets to me before I have my gloves on, I might very carefully hand them a piece of gauze and ask them to stop their own bleeding while I put my gloves on. So I don't touch them with my hands, with my bare hands. Even if it's somebody I know well, I've known them for 5 years, we assume every person has an unknown bloodborne virus or bloodborne pathogen because we don't know any different. that's what universal precautions means. And once we're done with cleaning up the wound, we have it covered, they're back in play. We have to be careful with cleaning up all of the items that have been bloodied that may have been left on the floor or on the ground. And we want to use gloves while we're cleaning those up. And then once we've cleaned everything up and put it in an appropriate package to be disposed of, we also want to be very careful when we take our gloves off. We want to try not to touch any blood on our gloves to any bare skin. So there's a very specific way that we take gloves off as well. And I will go over that in class when we go over our wound care lab. Skin that comes into contact with blood or bodily fluids should be washed immediately with soap and water if it's available. If somebody, or if you're, for me, if I'm on the rugby field, I can't go running to the bathroom every time I'm exposed to blood. So I will hand sanitize very well before I touch anything else after I've removed my gloves. And then I'll wash my hands with soap and water as soon as I leave the field, generally speaking. We do want to wash hands and or sanitize between patients in a physical therapy setting or in a hospital setting as well. And between athletes in an athletic training room to try to minimize the spread of any type of infection that we can. Other supplies and equipment that are important as far as cleaning up blood on surfaces and controlling spread of bloodborne pathogens through touching contaminated objects would be things like keeping a supply with chlorine bleach, antiseptics, containers for soiled equipment and uniforms, wound care equipment, and sharps containers. So if you have something that has blood or bodily fluids on, say for instance, somebody grabbed a towel to give somebody who had a bloody nose before you could get to them and clean them up with gauze, then we're definitely going to want to make sure that towel and their uniform, if it needs to be removed, is placed into a bag that's labeled clearly as having blood on it. If we have items that are saturated in blood like gauze or something like that, we need to make sure those get into a biohazard bag, which is going to be labeled in orange or red with a warning label. And then that should be disposed of in an appropriate disposal receptacle. So biohazard bags are not placed in a regular trash can. Gloves and bandages should be placed in sealed bags prior to disposal in a regular trash can. So technically, if something isn't saturated in blood, as long as we're making sure that somebody digging through the trash wouldn't be exposed to it, it should be fine. So a bandage with a little bit of blood on it, or gloves with some slight blood on them is not as big of a deal. It doesn't necessarily have to go in a biohazard bag. So 90% of the time with the blood that I'm dealing with on the field, it's not necessary to use a biohazard bag. Usually when I have somebody who has blood, I'll clean them up, get all the gauze in my glove, carefully remove my glove so it's inside the glove, and then I put it inside of another plastic bag and tie it off before I dispose of it in the trash can. So I try to do my best to double bag it, basically, to even be a little more safe. If we have something like a floor or a mat that has been bled on or has some bodily fluids on it, then we want to disinfect that with a solution of bleach and water. So it's 1 unit of bleach to 10 units of water. That's very effective, and it's less expensive than most of the commercial disinfectants you can buy. There are other solutions you can use as well, but that's usually the cheapest. Contaminated towels or clothing or anything like that should be labeled and separated from other laundry and washed in hot water for at least 25 minutes. So if there is an equipment manager who does laundry for an athletic team, then they need to know for sure that something has blood on it. If it's something that is mine that has gotten blood on it, then I'll make sure and take it home and wash it appropriately. As far as if somebody has used a needle, or if I've used a scalpel or a razor blade on somebody, you want to use extreme care when you're handling sharps because if somebody else's bodily fluids are on a needle and then it pricks me, I've had an exposure. So we want to be very, very careful with sharps. And to be completely honest, I've had a lot of experience with dealing with sharps, and I still sometimes get myself on occasion. I give my cat fluids daily because of a kidney disease, and I've gotten myself probably 2 or 3 times with her needles, even when I was trying to be very careful. Thankfully, she does not have hepatitis, so at least I'm lucky that way. But you want to be very careful when you're dealing with needles and things like that, and we want to dispose of them in a red sharps container, such as the one shown below. Scissors and tweezers should be sterilized and disinfected regularly. Usually those aren't things that we have to dispose of, although in a hospital setting, if scissors or tweezers needed to be sterile, then they would have to be disposed of after the fact. In an athletic training room, we don't need them to be sterile usually because we're not dealing with completely open wounds as much as in a hospital setting. As far as post-exposure management, that would be, if you stuck yourself with a needle with somebody else's blood on it, that would be an exposure. Or one time when I was cleaning up a rugby player, he moved his hands and ended up spraying blood into my mouth when I was trying to clean his hands. So I guess technically that was an exposure, although I never reported it because I didn't feel like the risk was very high of me getting sick from that. But if somebody's had an exposure, the athlete or employee should have a confidential medical evaluation that documents the exposure route, so blood in the mouth, the source or the individual, the identification of the source or the individual. So in that case, it would have been that specific rugby player. The person would have to have a blood test, counseling, and evaluation of any reported illnesses. So that's basically what happens with the medical evaluation, and it's confidential, so it's not anybody else's business other than the individual who's being tested and possibly human resources, because they would be referring that person probably to workers' comp physician. As far as laws that pertain to reporting and notification of results relative to confidentiality, that can be different state to state, but generally speaking, individuals are not allowed to report exposure to others. So if I wanted to tell somebody else that I'd had an exposure, that's fine. But if my supervisor told somebody else, that would not be allowed. If I were to know that one of my athletes had an exposure, I would not be allowed to tell the coach because it's not medically relevant to the coach, and it's not their it's technically not their business. As far as caring for skin wounds, this is something that might need to be done, or would need to be done for sure as an athletic trainer, in hospital setting. Physical therapists may do this on occasion. Personal trainers may do this on occasion if somebody becomes injured in a fitness center. But caring for skin wounds are extremely common in sports, especially specific sports. But there could be lots of different ways people injure their skin. This can happen from friction, so rubbing, scraping, like on the ground, pressure or impact, tearing, cutting, and penetration. So, somebody could be cut by a metal spike, say for instance, for track. I've seen that happen a lot, actually. Or somebody could have a penetrating injury where they fall on something that's sharp on accident on the sideline, or historically people have walked into a javelin throw or something crazy like that. Javelin's not very common at lower levels anymore, partially because of the danger associated there. So you won't see javelin throw as much in high school settings anymore. Bleeding can be categorized in different ways. So arterial bleeding is, generally speaking, bright red, There's venous bleeding. That tends to be darker because there's not as much oxygen in the blood. Capillary bleeding tends to be more of an ooze. You can have internal bleeding as well, so like a bruise or internal abdominal bleeding or thoracic bleeding that could cause damage to the internal organs. And external bleeding would be just our normal skin bleeding. So again, with venous bleeding, we're going to have, it's going to be dark red with a continuous flow. So for those of you who like horror movies, which I don't personally, if you see somebody who gets their throat slit in a horror movie, they grab their throat. With venous bleeding, that's going to be the blood that oozes out, right? That's kind of just trickling out through their fingers. If somebody has their throat slit and the director is trying to show arterial bleeding, that will be the bright red blood that's spurting out all over the walls. Okay, so those two are different. The blood pressure is higher in the arteries than in the veins, so that's part of why the blood flow is slower. Capillary bleeding is like what you see when you scrape your knee. Say, for instance, it starts off by being usually kind of a whitish wound, and then all of a sudden you'll see the little drops of blood starting to come up throughout the abrasion. That's more capillary bleeding. Not the exuding from the tissue is that little bubbling up of the blood. It's also reddish. So when it comes to bleeding, the arterial bleeding is going to be kind of the scariest because it's going to allow the individual to lose the most blood. So we really want to get that under control as quickly as possible. But all bleeding we want to control as well as we can. So on this page, we're showing pictures of the different types of wounds. So the most superficial type of wound is called an abrasion. The top layer of the skin will get scraped, exposing the capillaries and causing that oozing blood. The thing with abrasions is that we have a large exposure to dirt and or foreign materials with abrasions, so that can increase our risk of infection, especially on a larger abrasion like in that top picture on the slide. Usually abrasions are pretty shallow, but they can be a little deeper, and if an abrasion is shallow versus deep, they're actually going to heal slightly differently. A laceration could happen in a couple different ways. Most commonly, a sharp object will tear the tissue, and you'll get a wound with jagged edges, like the individual with the large wound over his or under his eyebrow, over his eye in that picture on the slide. Also, with lacerations, they can be caused by a blunt object hitting the face. So forehead to forehead is somewhat common in sports. In construction, maybe somebody gets hit in the head with a piece of 4x4 or something like that, and that can also cause a laceration. Puncture wounds, like the bottom picture on the left with the toe, that's a puncture wound. They can easily occur during activity, and they technically could be fatal if we're talking about the javelin throw going into a torso or something like that. Technically, the person stepping on the nail hopefully has a less of a chance of having a fatal injury there. But if you get impaled by a rusty object, you can get tetanus from that. So tetanus bacillus is a kind of bacteria that can go into the bloodstream, and it can make the person very sick, and it can cause death if the person has not been vaccinated against tetanus and is not treated appropriately. Severe lacerations and or puncture wounds should get referred to a physician for suturing possibly and or antibiotics. That nail through the toe is pretty interesting. I'm sure they went to the emergency room for that because they weren't going to want to pull it out from the toe. That's why it's really important in construction sites and places like that where there are a lot of sharp objects lying around to wear steel-toed boots that are heavily reinforced so that doesn't happen. Avulsion wounds, like the middle picture on the bottom, happen when skin is torn from the body, and that can cause major bleeding. So in this particular individual's case, my guess is that he was wearing his wedding ring while operating heavy machinery, and something got caught in his ring and it pulled off all the skin on his finger. A similar thing actually happened to Jimmy Fallon a couple years ago when he tripped walking through his living room and he caught his wedding ring on something, and it desheathed his finger like this. Very weird. That was a very weird situation. But this is why we remove rings when we are playing sports or operating machinery, especially anything that has like a torquing or twisting mechanism to it. There are lots of good reasons to remove rings while we're playing sports, but this is one of them. If somebody does have a tissue avulsion that you're taking care of, or this happens with one of your friends, we want to take that tissue and wrap it in moist gauze and then put it in a plastic bag, try to keep it as sterile as possible. Then we'll put the bag in ice water to try to keep that tissue as cold as possible to keep it from getting bacteria and different organisms growing in it. And then we want to take that with us to the hospital for possible reattachment if they're able to do that. Next door to the nasty finger, on the right, on the bottom part of the page, we see an incision. So this individual had some kind of thoracic surgery, possibly a heart surgery or lung surgery, and they had an incision down the middle of their chest. So an incision is a wound with smooth edges. So incisions are commonly seen, with surgery, say for instance, where a physician is cutting somebody with a scalpel. So that's not going to be a jagged wound, that's going to be a cleaner, thinner line. As far as wound care goes, immediate care for a wound should happen immediately, as soon as possible, to try to minimize the growth of any type of pathogens that could get into the body from having that open skin. And all wounds should be treated as though they are contaminated. So we just assume that whatever caused the wound also introduced some bacteria or viruses or other pathogens into the body. So we're going to try to minimize any chance of infection by cleaning the wound with soap, water, and or a sterile solution. So ideally, if we can, we want to have the person wash their wound with soap and water as quickly as possible. And then we will try to put a sterile solution on it. Betadine is best. If you've ever had surgery yourself, after surgery, if you looked at your body part that was operated on, you probably noticed that your skin was a little yellow. That's because they cleaned you up with betadine prior to surgery. So betadine is very effective in taking care of any pathogens that are present in the skin or on the skin or in a wound. It's best to try to avoid hydrogen peroxide. That is something that people historically have used to clean wounds, but it actually kind of macerates or eats up the tissue a little bit, and it also washes or cleans away a lot of the substances that help the skin heal, that come to the area to try to help the skin heal. So ideally, don't use hydrogen peroxide. Betadine is better, or soap and water actually works fine most of the time. That's immediate care of a wound. After we have cleaned the wound to the best of our ability at that time, we want to apply a dressing that will keep blood or any pathogens out of the wound and out of the blood. So we want to try to use a sterile dressing while there is fluid discharge present to help keep the wound clean. So if there's still bleeding, or if there's that oozing of the interstitial fluid before the scab forms, we're going to want to try to keep that wound covered. Occlusive dressings, such as the clear dressing that's being placed at the bottom right-hand side of the screen, can be really effective to help minimize scarring. Those are actually pretty neat. The occlusive dressing allows air in, but doesn't allow moisture out. So it can be really good for shallow abrasions and things like that we're trying to get to heal quickly. Because it helps to keep the wound moist, it's especially good for abrasions, for shallow abrasions. For a deeper abrasion, it's actually going to slow the healing process. The other thing that we would want to use would be an antibacterial ointment like Neosporin or triple antibiotic. They can be very effective for limiting bacterial growth and preventing the wound from sticking to a dressing. Ideally, I don't use gauze on any type of wound that is oozing or has fluid discharge, because it's going to make the gauze will stick to the wound and it will be painful to remove. The only exception to that rule would be with a deeper abrasion. We actually do want the scab to dry up, and the doctor would actually recommend you using gauze instead of a Band-Aid or something like that. But ideally, we'll have some kind of ointment for shallower wounds that will help keep them from sticking to whatever dressing we're putting on. Because of a chance of a skin reaction, we only want to use Neosporin for 2 to 3 days. If we feel like somebody still needs some help as far as keeping the wound from sticking after 2 to 3 days, then we can use something like petroleum jelly or Vaseline to keep the wound moist. So on this slide, we have a rundown of everything that we've gone through for the most part in this particular chapter. This particular checklist is from your textbook, and it just summarizes all of the different areas that we've discussed as far as practicing universal precautions and dealing with bloodborne pathogens. And you can review it on your own to try to make sure that all of that information has stuck in your brain. Another interesting topic with wound care is, are sutures really necessary? So sutures, stitches, those are used interchangeably, but sutures is the technical term for stitches. And this is actually pretty helpful information. I have spent many a Friday evening with an athlete in the emergency room waiting to get sutures. So it would be nice not to have to do that if you didn't need to with somebody you were caring for. So deep lacerations and incisions and occasionally punctures may require manual closure, such as sutures. Sometimes doctors or physician assistants or nurse practitioners will choose to use surgical glue, is what they call it. It's basically sterile crazy glue to close a wound. That might be appropriate possibly on an arm or a leg where a scar doesn't need to be as nice looking. I would personally never let somebody crazy glue my face because the scars usually don't turn out as well as if you get sutures. If somebody, I can say to an athlete on the field, wow, that laceration is pretty bad. I think you need to go to the emergency room to get sutures. But it doesn't really matter what I say. The decision is going to be made by a physician. We do have guidelines that we follow. So, if it's more than half a centimeter, a common guideline would be something along the lines of if a wound is more than a half a centimeter wide and a quarter centimeter deep, that might be a time somebody would suture. I've been doing this long enough that I can kind of look at something and say that's probably going to need sutures, but not everybody can tell that. As far as guidelines that I've previously followed due to what I've been told in the emergency room myself, is that sutures on extremities should be given within 12 hours. Some physicians won't suture a face after 6 hours, which sounds kind of like a long time, but if I have somebody who has a laceration on their face and then I cover it and then they've finished playing the game and then they go out to eat with the team and then they finally get to the emergency room, it's a busy night, and then they have to wait to see the doctor for 2 hours, that's really pushing that 6-hour window. So it's really not that long. So usually what I'll tell people is that they've had a laceration on their face that we covered to allow them to finish a game is to try to get to maybe go grab some food real quick and then hurry to the hospital as soon as they can to make sure that they're not going to miss their time window. Having said that, my husband is a physician assistant in the ER, and he will do sutures farther out past these guidelines. These are just the most stringent guidelines that I've been exposed to. So I teach this just to make sure that people get to the emergency room in time to have sutures done. If a physician decides that a wound doesn't need sutures, they can use steri-strips or butterfly bandage or surgical glue. In these pictures on the bottom, on the left-hand side, and in the webbing of the thumb and forefinger, those are some sutures there. And then on the right-hand side, or yeah, on the right-hand side, those are steri strips that are placed on this pretty little girl's face. Again, for me, I wouldn't personally choose steri strips or glue on the face, especially not on a young child. I would prefer to do sutures if it's warranted, if there was any question. I have done steri strips on a longer but shallower laceration because a child's parent on a leg, because the child's parent and the child who was a teenager both decided that they didn't want to get sutures, and so they preferred me to try to just steri strip it. And she actually had a really great result. But I am very anal about how I do my steri strips, and I do them very particularly to make sure that the person has the best result possible. Not all clinicians are like that. So even if we have done our best to try to prevent infection, sometimes people will still get wound infections, and or sometimes people don't treat their own wounds as well, so they will get infections. Some signs of infection that are important to be aware of would be the same as those for inflammation. So if you think inflammation, fire, flame, that's helpful to think of. So if somebody has an infection, they're going to have pain in the wound area. They're going to have possibly heat. So if we touch it, it'll feel hot to our touch. Redness, especially redness that's streaking out from the wound or up towards the heart, or up or down towards the heart, depending on where you're looking. Swelling, possibly. And they could have disordered function. So say, for instance, in that photograph on the right on the slide of the person's foot, they probably are not able to wear shoes because their foot is so swollen, and they're probably having a difficult time walking due to pain. So their function of their foot is not normal. Pus can form due to accumulation of white blood cells, or WBCs. So say, for instance, in that picture on the left, it looks like we're getting a little pus in the wound. When you have an abrasion or something like that and you have clear fluid coming out of the wound, that clear fluid is normal. That's called interstitial fluid. That is not pus. Sometimes people get confused, or sometimes you get kind of a kind of sticky substance that starts to form when the scab starts to form. That's not pus. Pus is cottage cheese-like. It's kind of gross. But it's not normal in a normal wound. If somebody has a bad infection and they let it go, then the person can get a fever as the infection spreads throughout the body, and the immune system tries to fight it. So fevers happen when our immune system is trying to fight off pathogens. Most wound infections can be treated with antibiotics, either triple antibiotic, possibly, although it's usually not a strong enough thing. Oral antibiotics are more common, or in certain cases, the person is going to need IV antibiotics, and in that case, they will have to be admitted to the hospital. If you notice on the person's foot, on the right-hand slide, they have a circle around the wound with a marker or a pen. So what happened there was that they had this infection that started, and they'd gone to the doctor. The doctor drew a circle around the wound, which was probably at that time about maybe half a centimeter in diameter, or half a centimeter around the border of the wound, and told or maybe less, it depends on the person, but it was around the border of the wound, so it wasn't originally on the red spot. And the doctor said to the person, if the redness goes out to touch this circle that I just drew on your foot, come back, and we'll see if you need further treatment. So this person is probably on their second visit to the doctor because their redness of their wound has reached the circle part of the line. So it's basically an indication that the infection is spreading and is not responding to whatever treatment was given in the first place. So those are signs of wound infection, and that is the conclusion of our chapter lecture.